Welcome back to the Family Docs Podcast, Treating Addiction in Primary Care. Brought to you by the California Academy of Family Physicians. Addiction medicine is family medicine. It is our final podcast in this series, and you're in for a treat. Hopefully, you've learned that treating our patients with addiction is not only much less complicated than we thought, it's also much more rewarding than we ever thought possible. Today, you will hear from two recognized leaders in addiction, both family physicians, and both sharing their thoughts about why family physicians need to offer treatment services. Dr. Carol Havens recently retired as the Director of Physician Education and Development at the Kaiser Permanente Medical Care Program, Northern California region, and was a staff physician of Chemical Dependency and Recovery Program at Kaiser Permanente. Dr. Mario San Bartolome is also board certified in both family medicine and addiction medicine. He has experience in all levels of care related to substance use disorders, serves vulnerable populations through FQHCs in Orange County, and is very active in both American Society of Addiction Medicine and the California Society of Addiction Medicine, where he serves on the board of directors. I know you're going to enjoy listening to these two experts, so Dr. Havens, take it away.
Hi, I'm Carol. Welcome to the next episode of our podcast series. I am a family physician and addiction medicine specialist. Joining me today is Mario San Bartolome. Mario, I'm thrilled to have you here today, and I'm really looking forward to this conversation.
Thanks, Carol. I'm really happy to be here. And I'm also a family physician and addiction medicine specialist, and have worked pretty much in every area of addiction medicine, as well as in the integration process at a clinic level of substance use disorder treatment, as well as in primary care. So I'm really excited to talk to our family medicine folks.
And it's great that you have that experience, and as a family physician that you can certainly identify with what our docs are experiencing. And as you know, in this series, we've really tried to encourage providers to consider providing MOUD in their clinic setting. And certainly for a lot of people, there is no other option. There are no addiction medicine specialists in their areas, or their insurance won't cover it. And so their only option to get treatment for substance use disorder is through their primary care provider. So as a family physician, what are the benefits that you see of providing MOUD in your clinic?
Really, there are so many benefits, and it's not really unlike the various benefits that you get from a lot of other conditions that oftentimes fall in other subspecialties, but can be managed in a primary care setting in an integrated fashion by somebody that knows you very well. But in the case of substance use disorders, you almost can't talk about the treatment of substance use disorders without discussing stigma, because stigma kills. And the fact that you can be at your primary care doc's office and he or she that knows you, they may have been with you from a time when you were a lot younger and many, many years. They may also be treating other family members and understand the dynamics of your family, because at the heart and the root of addictions is really, it's a family disorder too. And so to understand that aspect of things really helps to begin the process of almost like normalizing it. So a lot of people don't get access to treatment, and some of that's a societal type of thing. And part of the reason why we're talking about it here, right, to have access to the resources, which means a physician that is trained and open to seeing this patient population and understanding some of the intricacies. But there are many reasons why a family physician's office really is geared perfect for it. There are screens that already happen. And if you're a family doc that thinks that these patients are not in my clinic, I will tell you, they are already in your clinic. These can range from folks that are being treated for chronic pain issues and have been exposed to opioids. There can be folks that also have co-use. So there may be some benzodiazepine use along with opioids, but these people are already in your clinic and you might be treating them for anxiety disorders and pain disorders, but they're already there. So isn't it wonderful to address this particular disorder in the setting that they're already comfortable in? And so to me, it decreases the stigma, which means increased engagement. And the name of the game for treatment, particularly in MOUD, is engagement. Because if people don't show up, then they don't get treatment. And we've seen this, and it's panned out in studies, particularly around certain groups where it's been even more significant, such as in the perinatal population, where when there's a co-location, so if that family doc is providing prenatal care, and it would go the same if it were an obstetrician, right? If they're providing the prenatal care and also the MOUD in the same location, the likelihood of that woman showing up for treatment increases astronomically, which means better outcomes at the end.
The actual incidence and prevalence of opioid use disorder is a little uncertain, but it's probably somewhere between 3.5% and 4% of the U.S. population. So I'm always amazed at the number of our colleagues who say, I don't have any patients in my panel that have opioid use disorder. And it's like, seriously? If 4% of the U.S. has an opioid use disorder, and you have a panel of, let's just say, 2,000 patients, what's that, 50 patients statistically in your panel have opioid use disorder. And you may not know it. You probably don't know it. And so it's important that people, one, recognize those patients are in their practice, and two, ask. It's amazing to me. People will not ask the questions. And sometimes they don't ask because they just don't think their patients have it. And sometimes they don't ask because they don't know what to do with it. So hopefully you realize by now that your patients do have it. And second, we're going to help you with what to do about it so that when you ask and get the answer, you can feel like you can do something for them.
And some of those times, it doesn't have to necessarily even be that you're suspecting a frank opioid use disorder. It could be some problematic use of opioids where it still requires your discussion. I was having a discussion with somebody this week who is somebody with an opioid use disorder history, and she was caregiving for her father who was entering hospice. So you know what? I have to have a conversation with her. Hey, guess what? I know in hospice, a lot of medications get laid around, and you're the caregiver. We need to talk about this just to keep you safe, to keep the whole process safe. And so it doesn't necessarily always come down to an active disorder, but these are the kind of things as a family physician you would be interested in anyways, to avoid falls, to avoid not just the overdoses, but even just sedation in general. So these patients are definitely there. And unfortunately, among a lot of society, and it has trickled, of course, into groups of physicians of all specialties, is that there's this idea that there's a stereotype. Like this person in front of you needs to be this toothless person with lesions on their face and no shoe and smelling bad and homeless. And that's not the case. That's not the majority of folks. There are people that have that degree of social determinant challenges and possibly co-occurring disorders from the mental health side that just make it even more complicated. But the vast majority, particularly in the case of a family medicine doc's office, you want to be able to catch upstream, maybe even before it gets to that point. So these interventions and appropriate screens, which we all know about, we know about SBIRT, we've heard about that for years, and there are a lot of different options for what to use as a screener. But to arm yourself with the ability to affect the safety and quality of life of your patient, regardless of whether you end up having a diagnosis of an opioid use disorder or not, because now we have crossed into this area where we are even using medications like buprenorphine for pain. And of course, they do exist for the indication of pain in say like a transdermal formulation, but even the ones that were traditionally thought of, the sublingual type, as only for the indication of opioid use disorder, there can be various ways to approach that a family physician needs to know without being an addiction specialist, and they can use, of course.
We adopted a universal 2-question screen for alcohol abuse, and all of our patients, I was with Kaiser in Northern California, and all of our patients get screened at least once a year for alcohol abuse, and we need to adopt a universal screen for other substance abuse as well. Once you make it a universal thing, it's not I'm asking this because I'm suspicious of you. I'm asking this because I ask this of all my patients, because you're absolutely right, Mario. I want to know. I want to know with all of my patients about their use of substances so that we can talk about what the risks might be, what they should be thinking about, or how they should be considering this. And I think that helps to lessen the stigma as well. I'm not suspicious of you specifically. In fact, I don't know if I should be suspicious of you. I just ask this of everybody.
Yeah, and it's okay to have the conversation about why you're asking as well, right? So as a family physician, I'm concerned about you in general. And in general, I want you to have a high quality of life, and I want you to be safe. And whether that's something that I'm doing through appropriate medication reconciliation when you come in after being seen at the hospital, or anything else that I do. So it can also be quite okay to talk to folks about why there may be an issue. So if there are flags, if you check the cures report and there's something there that needs to be discussed, it's okay to simply put it out there that this is something that appears to possibly be a problem. I want to talk to you about it, because if it is, I want to help you. And that discussion then needs to communicate a non-judgmental type of approach, number one. Number two, it needs to also communicate your caring. And you'll be surprised. One of the first things that I noticed when I entered the field of addiction medicine, where it kind of captured more than half of what I was doing early on, over 15 years ago, was some of the things that I heard about people that had substance use disorders from some of my colleagues were that they expected people to be liars. And I thought, well, that harkens back to medical school when one of your faculty said to you, you have to check yourself. Your own emotions impact what you do. So if you have a negative emotion about this patient, you need to check that. So what I found out, and I can tell you after now seeing thousands of patients, that is not the case. In fact, my patients, I primarily see folks that have substance use disorders, and they are some of the most honest in terms of what they divulge to you. It's really a privileged position to be in. I mean, they're telling you things. There's so many folks that have substance use disorders that have experienced traumas. And some of the things that they will tell you that have happened to them, really the amount of honesty you need to be able to talk about those things, or to be able to address shame and the cycle of their perceived failures over time, the helplessness that they might experience. And they communicate that to you. What you do with that and how delicate you handle that is of grave importance, because if they're opening up to you, you may be the first avenue into helping them change some behaviors with or without medications. And you're meeting them where they're at. So guess what? When you do talk about something, you don't have to solve all of the problems of the world in one visit. And so it can be often overwhelming. And I spend a good amount of my time helping my colleagues to also not be fearful of what they may have as a stereotype, that this patient's going to come in, they're going to take all of my time, and that weird feeling you get in your gut when you think, oh, this is going to be somebody, and I'm going to use in air quotes here the idea of a drug seeker. We now have kind of reached a point where we've also understand that language matters. And so we need to continue to arm ourselves around non-stigmatizing language, to not use these pejorative terms like junkie, and you'll often see sometimes in some parts of the subculture in substance use, like in the 12-step world, some of the folks still use some of the terms among their own mutual support groups. But as professionals, we're trying to get better. So even the idea of arming yourself with better information around what substance use disorders are, what these people really bring to the table as far as co-occurring disorders, because at the heart of family medicine is that you're not picking and choosing an organ. And substance use disorders deals heavily with the nervous system. However, it also involves hepatitis C, HIV, various other infectious diseases, endocarditis. It also can impact co-occurring disorders around the mental health side, where there are substance-induced anxiety disorders and depressive symptoms. So there are several ways that you can use family medicine to really just extend the treatment of substance use disorders without being an addiction specialist.
There were more than 100,000 people who died from overdoses last year. This is continuing to rise. These are our patients. Before I started integrating substance use disorder care into my everyday practice, I was not providing the kind of care my patients needed. Are you wanting to learn more about introducing medication for opioid use disorder into your practice? You can connect with a peer to support you through this journey and questions you may have before jumping in. CAFP is building an MAT Mood Champions Network. Visit familydocs.org/SUD for details.
I remember when I was in my training, one of my attendings said, the great thing about family medicine is if you don't get everything addressed the first time, you'll get more chances. And you're right. Just bringing the subject up in a non-judgmental, open manner, that you're willing to talk about this, that you're not going to pass judgment on them, but this is a medical problem just like any other medical problems, allows them to then open up to you in exchange. And it may not be that time, because it may be the first time that anybody's ever talked to them about it and they're not sure about it. But if you keep the conversation going in subsequent visits, eventually they may open up to you and start sharing some of their stories with you. And that's one of the great things about family medicine is we get these multiple opportunities. They come in for a recheck on their hypertension. You can also ask them about their substance use, because that, by the way, affects their blood pressure and vice versa. So it's a great opportunity. So I think there's a lot of benefits certainly to patients to being treated in a primary care setting, but I think benefits to the physician as well, because we also know that patients with a substance use disorder who are treated for that substance use disorder utilize services at a much lower rate than those who have a substance use disorder which is untreated.
I agree, and that makes me think as well of one of the things that we oftentimes in family medicine spend our time is we have these goals that we learn about in science, like hemoglobin A1C goals, goals for blood pressure, goals for compliance with medications and proper INRs, and that's all fine. However, try controlling those things if somebody's in an uncontrolled substance use disorder state. Good luck. Good luck managing that insulin pump if somebody's using meth every day or alcohol. We know some of these actually affect directly. So alcohol use disorders directly affect blood pressure. It's not a question. We know this. And so adding more of a calcium channel blocker or an ACE inhibitor, that's not the question. It's, well, what else do we need to do to help this person to have lower risk factors to be able to control something that may be a co-occurring disorder? So it's actually, from the standpoint of a physician, it makes sense no matter what. As a family physician, one of the other beautiful things is that oftentimes you'll get a lot of collateral information. And that means, husband and wife. Wife has husband by the ear. You need to talk about this because I'm about to leave this marriage. What you do with that matters so much, because at that point you can become the first source. And I can tell you, one of the most daunting things that exists is, where do I go? What do I do if I have a substance use disorder? Do you Google it? Well, if you Google it, you're going to get a million ads for rehabs. And is that what I need? Or there may be a whole bunch of articles on various medications. They might have heard a Joe Rogan podcast about maybe they need to do psilocybin. There's just so much information everywhere. Where do they start? As a family physician, you are the beginning of that funnel. And we know that only around 11% of folks that have substance use disorders get treatment at the end of the day by a professional. And so you start that process of helping engage them in a direction. So arming yourself with what is now legal to do without having to have a special X waiver, a DEA, to be able to provide a medication, access to a medication such as buprenorphine. There are others, of course, that can be used for both medications for opioid use disorder and alcohol use disorder, but there's no longer that restriction that we had. So it's an amazing time. Now, with that comes the same responsibility of understanding how to use the medication, the same responsibility about how to manage it responsibly and chart and do all the things that we normally would do. That's no different than when you learn how to manage insulin, right? A very important medication.
We've talked a lot about certainly benefits to patients to being able to get their care within the primary care clinic, and benefits to the physicians as well. But it's a little scary the first time that you think about prescribing buprenorphine or starting to treat substance use disorders. And I liken it to the first time that you prescribed insulin. That was a little scary too in the clinic. So one of the barriers to physicians being willing to take this on, even if they want to, and increasingly our students and residents are enthusiastic about wanting to include this in their practice. But one of the barriers is, I'm just not sure about how to do this. What can I do? How can we help those people get more comfortable with this?
Yeah, that's a great question, because there have been, just from a historical perspective, things that have become barriers. We discussed a little while ago of some of them that are going away, like the need for having a special DEA waiver, but the training's still important to get to be able to use any medication. So this is actually still no difference than the insulin or any other medication that, when do you use it? Are there considerations around renal function or liver function, or how do you use it? Unfortunately, over time, and because it's a Schedule III substance in terms of buprenorphine, there's also been a lot of mysticism and a lot of fear from providers. And I felt it when I first started. Before I ever was an addiction specialist, I did provide folks with buprenorphine and did my training, but I was fearful of the DEA. I was fearful of all sorts of folks. Am I going to have an office full of people that only want services for opioid use disorder? There were a lot of fears. Also, the fear of one of the most important parts of the process of using the medication is the part of the induction or the initiation. And that's one of the most complicated parts of it, is how do you start the med? Now, look, at one point, somebody taught you how to use Coumadin. And that's something that requires a thought process for starting. And then guess what you have to do after you start it? Well, you have to monitor it. And then when you monitor it, well, what intervals? Well, all of that's been laid out. So my suggestion is, number one is don't fear what you already know how to do, which is you have the scaffolding already of how to think of problems and how to use medication to understand indications, diagnostic criteria, and then monitoring. These medications are actually, and this is one thing that took me a while to learn, when you think about what the person with an opioid use disorder is doing in the street, and let's just say what that is. They might be injecting heroin, they might be injecting fentanyl, or maybe being exposed to multiple other substances all at once. Very dramatic, the potential for a bad outcome, super high. Well, guess what? What you would be providing from the standpoint of the buprenorphine is orders of magnitude safer than what they're doing in the street. So you're not going to hurt them if you take your own basic precautions like a family physician that's trained well would normally do, is to just to understand how to start a medication and some of the principles behind it. And then the proper universal precautions around monitoring, just like you would with any substance that is a controlled substance, which means you're checking cures reports, you're doing appropriate urine drug testing, and then you're also engaging the person in as much mutual support as well as the potential for psychotherapy and psychoeducation that they may need, and you're doing appropriate screenings. These are all the same things that I can point out multiple examples that you already do. You already do it for folks that have chronic illnesses, because when we think of the model of a chronic illness, a substance use disorder is not very different. It has relapses. It's not something that goes away with one treatment, right? You don't come in with a hemoglobin A1C of 12 and get one shot of insulin and then you're good to go. That's not how it works. And all of those co-occurring things, just like in the case of, say, diabetes, that somebody might have a retinopathy, you're still looking for neuropathy issues, all those things that might go along with diabetes, not unlike in substance use disorders that you're still doing other screenings for sexually transmitted infections and other things. So utilize also the fact that unlike many other conditions, in the case of medications for opioid use disorder, there are resources for mentoring. PCSS, through CAFP, there are American Society of Addiction Medicine, the California Society of Addiction Medicine. There's various options for free mentorship. For example, I serve as basically the curbside consult for the whole county of Orange. People just have my cell phone and they can call me at bedside if they needed to ask me questions about buprenorphine, naltrexone, any of these medications that we'll use in treatment. So there are lots of folks like me and like Carol, like others, that will provide mentorship. So use that and then become that. You learned see one, do one, teach one a long time ago. And it's no different. So when you get comfortable with providing the service, and one of the things that I learned is that it made me think of back in the day when I wrote my personal statement for medical school. We come into this process, and especially folks that are family medicine oriented, because we tend to be the corniest of the group oftentimes, right? We definitely have a connection with family. We're okay with chaos. A 3-year-old in the room with mom, also holding an infant who's there with grandpa for grandpa's assessment for dementia. And all of it's happening in the same room. And we're comfortable with that because we signed up for that. And so to me, understanding that whole dynamic of what you can provide really makes these dramatic changes something that really feeds your soul as well. This is what I found. I found that this change that can happen, it's not just an A1C that goes from one number to another number. It's an entire generation that is right before your eyes that can change, it can stabilize, and then improve. It's quite dramatic. And using some of the medications for these disorders can be very, very dramatic. So lots of mentorship opportunities. See one, do one, teach one. So be the resource in your community. Once you get enough experience, be the person that goes to the senior center and gives a 15-minute talk about polypharmacy or pain, and then somewhere in there you can talk about substance use, or for some of the adolescents that come in, because we're seeing more and more use from these groups. Be that community resource as well. And don't fear it, because you already have the chops to do it. You already have it. And it's just one more medication. And like I said, it's actually safer than what they're already doing. One of the things that you'll learn as well is that the same medication, like buprenorphine, actually has properties that decrease the likelihood of some of the things that we always fear, like overdoses, respiratory depression, and some of these things. And so once we arm ourselves with the right information, then you can offer the service and really change people's lives.
To learn more about mood, visit CAFP's Homeroom, an online learning platform with online activities that's available 24/7 on a range of topics, from reproductive health to chronic low back pain, ACEs to osteoarthritis. Visit familydocs.org/campus to find enduring activities that address so many aspects of substance use disorder and how to treat it as family physicians. To go deeper into how and why mood is critical, visit familydocs.org/campus to find these accredited resources.
So many great comments, Mario. I started practicing addiction medicine before bupe was approved. So back in the days when the only treatment that we had was either methadone clinics, which nobody could access or wanted to access, or abstinence. And I'll tell you, using bupe in someone with an opioid use disorder with MOUD is a whole lot easier than trying to get them through withdrawal from opioids, which was kind of a nightmare. So you're absolutely right. This is a whole lot easier than doing that. And I will often tell people that when we want to do something new, or when we're thinking about taking on a new thing, we get freaked out by the whole universe of possibilities and what might happen or what we need to do. And instead, I encourage people, just take it one step at a time. Start with, if you think this person has an opioid use disorder, go through the steps, make the diagnosis, do the appropriate things. Once you've made the diagnosis, then take the next step and just take it one step at a time. And once you get through all those early steps, you can start breathing normally again. You've made the diagnosis and you know what to do. You have options, you have treatments. You have medications that you can use. And you're absolutely right. Having someone there to virtually hold your hand to say, you're right, this person looks like they would benefit from this. Here's what I would do, or here's what you could consider doing to start the buprenorphine. Do this, follow up with this, do this tomorrow, and gives people a sense that they really can do it, that there are steps that they can take, that it's pretty straightforward, and that it's something that's certainly well within their scope of practice. And I think one of the important things, Mari, I just love that you're a family doc doing this, because we know that physicians will change their practices not based on what some super specialist national expert tells them, but what someone who's like them tells them. So family docs who are thinking about doing this can look at you and say, wow, I'm a family doc, you're a family doc, you're doing this, somehow you started doing this, tell me how to do it as well. And I think that is such a valuable thing. You talked about once you become comfortable with it, become the person that people can go to. It absolutely is true. Putting yourself out there as someone who can help you get through the first 2 or 3 or 5 until you are now that person. And it may not be see one, do one, teach one. It may take 2 or 3, but still, the concept is the same. So I think it's really important to hear from people like you, Mario, who look like me, learned like me, practiced like me, and you're doing this.
I agree. And one of the other aspects that I think is important to consider for addressing the fears around providing this service for family docs is that when you provide medications for any of these disorders, you do not have to be an addiction treatment center. That is not what you're trying to do. And that is not what you're putting yourself out as. And that causes a lot of fear for people because they think, well, I don't know anything about being like a rehab. You're not going to become a rehab. These medications and the workflows that have been created, refined over years and years and years are perfectly acceptable in an outpatient setting, in a regular clinic, and for your own, not only your own patients, but guess what? We have an entire movement right now of helping patients with substance use disorders at the level of the emergency department. So if one of your patients hits the ER and they are started on buprenorphine, they need the connection out in the community for ongoing care. So that's where another very important part that a family physician can be key, because these ER docs don't have a lot of places to send people. So we are the heart and soul of, in some cases, the safety net, but without even being a safety net, I would say at the end of the day, when somebody has an issue, we're the one specialty that says, let me give it a crack. If somebody walks in, we don't say, well, no, I don't do that organ. I don't do that organ. Sorry, don't do that. We're the first line. And it could be that you might feel that in some cases, either it's more complicated than your level of training or your scope for that moment. And guess what? Those can be referred. If you're doing the part where you're identifying it and stabilizing the part that you can and educating the part that you can, that's awesome. That's still great. And then if you're more interested, you can continue to learn. So referrals can still happen. Use your resources from the standpoint of other champions in the community, and then become that champion. And remember, you don't have to become a treatment center. This fits quite well in an outpatient family medicine clinic.
Dr. Kahn, I think in one of the earlier sessions said addiction medicine is just good family medicine, which I think is absolutely what you're speaking to.
I've always felt that the one specialty that fits in what ended up becoming a subspecialty of addiction medicine really is family medicine. Because again, we don't say, oh, sorry, you're pregnant, I don't see you. Or, oh, you're too young, I don't see you. Or you're on the older side, I don't see you. We really integrate that and cradle to grave, because that disorder doesn't care about how old you are. We have folks that are born to mothers who use substances and struggle with withdrawal symptoms from neonatal abstinence, and also developmental issues that happen in toddlers and adolescents, depending on the substance, things like fetal alcohol syndrome, things that you already learned in getting your board in family medicine in the first place, actually. And all of these things really fits into the concept of a whole person care. And so substance use disorder as kind of an area, or addiction medicine, has suffered from not only the stigma that exists from the standpoint of a disorder, but it also has suffered from the siloing. And these silos have happened in the system. And that means that health plans, insurance companies, and others, county systems, they've siloed off substance use. And in some cases, in ridiculous ways. I remember seeing a patient who came to me on a Friday at 5 p.m., an abscess on her arm and a big red antecubital area. She was a bit thin. She came in with her mother. She had been using heroin. Her skin was, having a lot of other issues. And of course, as I go through the process of diagnosing her, talking to her about some of the options, I do a urine pregnancy test. She's pregnant. So now I have this young woman who's pregnant for the first time, has an abscess. Maybe she's going to have all these other problems. And because of insurance issues at the time, I was open to be able to treat her infection. But because of the way that behavioral health was carved out from services, I was not able to really prescribe her a medication that I was perfectly able to prescribe her and trained to do. That's some of the silliness. So we need to not be on the silly side as a specialty. So we have the ability to be able to be as comprehensive as possible. And as we sort out in society these siloing and stigmatization that happens with this condition, we still need to be the source of caring, of complete care for the family.
I've often talked about what I call the premise and the promise of family medicine. And the premise being that we are not organ systems separated from others. Our heart is not separate from our liver, which is not separate from our kidneys, which is not separate from our brains. What happens to us in childhood is not separate from what happens to us in adult or older age. What happens to us alone doesn't just affect us, it affects our families as well. And so there's this whole web of interconnectedness that family medicine recognizes. And the promise is that we will work with you within that web of all of those interconnections to help you with all of those things, which you're right, doesn't mean that we can take care of everything. They may very well be some patients whose disease is such that it's beyond what we can really comfortably take care of. And yes, there are specialists out there that we can refer to. And I absolutely believe in the importance of family physicians in providing MOUD, but I don't want to discount then or to negate other primary care specialties who are also taking this on, because it's really important that we get our pediatricians and our general internal medicine docs and the obstetricians involved in this as well. And you mentioned that emergency rooms increasingly are now starting to start treatment for opioid use disorder, which is great. But if we can get people at all of those places more involved in providing care for substance use disorder, it's going to be better for everybody. Yes, absolutely, family physicians should be doing this, but so should pediatricians and obstetricians and other specialists as well.
Agree 100%. Even if part of what you do is to really address understanding what an addiction is. And I think that's an important piece. I think with the exception of in the last several years, traditionally, we don't do a lot of training in addiction-related issues in residency for various reasons. But there are not a lot of questions on our boards about it, and so they don't train you to those. Really, it's important that you understand just even what an addiction is. And that will, I would say, be the first step to begin answering some of the questions that will come up in your mind if you're new to the concept of having access to be able to prescribe medications for opioid use disorder. And one of the biggest questions that I hear from some of my colleagues, as well as just folks in the community, is that, isn't it just exchanging one addiction for another? And in order to really discuss that, I mean, it can be discussed through a lot of lenses, but one way is to really first understand what addiction is and to be able to understand that it's not so much about the chemical in terms of which one you're using and what the process of addiction is as far as some of the other impacts on your life. Refer to the DSM-5 for that. Start looking at some of those. But it is absolutely not that. You would not be doing that. That's oftentimes one of the things that people get concerned about. It's beyond the scope of our talk here, but I would say arm yourself first with the right information, as basic as the definition of what addiction is. And one of the other areas that I think is important to bring up, and this is probably a good topic for another podcast as well, and that it involves somebody's degree of comfort in starting to do something like this. And that's, what about the other substances? How often do we just see somebody that only uses opioids these days? And it's not very common. In my experience, most of my patients are polysubstance users. And so that's another point of fear for people, I think. What happens when that person's on 10 milligrams of Xanax, has a history of a seizure disorder, and is using fentanyl? That's a very reasonable thing to be concerned about. Where else can you get support? Where else can you get some of the training? But realize as well that, remember, you're already treating a lot of these folks, because you're seeing them for anxiety and depression. So some of these psychotropic meds actually come up either way.
And in that patient that you just referred to, you're treating their seizure disorder. You just don't know that they also have a substance use disorder in addition to it. So you may actually be making things a lot worse. And that's why the various hotlines and warm lines that are available here in California to people to be able to call and say, what should I do? And PCSS is terrific. You know, I've got this patient. What should I do? The ECHO series that they do of people bringing cases and having the experts discuss them. Those are all wonderful learning opportunities for people to get more education, to get more information so that they can become more comfortable about some of those things. And you're right. The fear of having that complicated polysubstance user who's also got diabetes and hypertension and goodness knows what else is a scary thing. But in reality, they're not going to be the majority of your patients. Yes, the majority of your patients may be using more than one substance, but it's not like they're going to have a million things going on. And if you just start one thing at a time, one step at a time, you can start getting through those things. But it is a scary thing.
That's why also understanding these principles around harm reduction are also important, because you need to give yourself permission to not solve all the problems in the world. And in family medicine, we want to assume responsibility for everything that's there. But guess what? Sometimes this concept of solving really is not the right framing. And we need to use a framework that's more along the line of harm reduction. And I always tell my patients, at the end of the day, what we're doing this for is to improve the quality of your life and to improve safety. The safety one is easy, right? That's the information we give them around naloxone, some education around substances. From the quality of life side, that could be a little bit more tricky to define to people. And I'm not talking about quality of life years and all these things that we would normally do in QI type stuff. At the end of the day, for a family that's there in front of you, mom, dad, their kid who they've seen overdose 3 times now, looking to you for help. When we discuss quality of life, it could really just end up meaning, are you in a state to love and be loved? And that can be as simple. It's not receptor physiology. And when you're in your disease, in any substance use disorder, it's really difficult to do either of those two things. So it really makes this concept of where it belongs in family medicine, for me to be, is super strong, because nowhere is there a group of trained folks that's the genesis of family medicine.
Boy, and that feels like a good place to end this. There's nothing else that we do in family medicine where you can make such a huge difference in a family, in a whole extended family, than by helping to treat a substance use disorder. And the joy of being able to do that, the honor, the privilege of being able to be a part of that. And I love the concept of the ability to love and be loved, because boy, when you get somebody who's got a substance use disorder, being loved is not easy, and loving is not easy, and loving yourself is not easy. And if you can get patients back to where they can do that, what a huge, huge accomplishment.
I hope these 2 powerhouse family physicians have helped you realize that providing services to our patients with addiction is not to be feared. As Dr. Mario said, we've got this. I want you to repeat it with me. We've got this. Don't fear what you already know. Just do it. Just as we manage other patients battling chronic conditions, we can manage these patients too. And it isn't just the patients, it's their families, their loved ones, their coworkers, and their community that are also suffering from the effects of addiction. But when someone looks to you for help, it can be as simple as Dr. Mario said, asking where this person sitting in front of you is in a state to love and be loved. Where else in healthcare system will these patients receive this compassionate care? And as Dr. Havens just concluded, there's nothing else in family medicine where you can make such a huge difference in a person's life and the lives of all those around someone battling addiction, trying to love and support them. For those providers still unsure about treating your patients with addiction, we get it. But we also hope this series has opened your mind to at least the possibilities and the importance of seeking more information so that you can be there for all your patients that need you, even those battling addiction. Now, there are many ways you've heard about how to get started. Consider CAFP's MOUD Champions Network at familydocs.org/SUD for connections with more experienced peers. There are so many more resources available to you. For example, the Bridges website, Providers Clinical Support System, or UCSF's National Clinician Consultation Center that offers support 24/7. For more information on how to connect to these resources, please visit the show notes. Now, take the first step, and then the next, and then the next one. And we hope you'll soon be experiencing the joy and privilege of serving some of the most thankful and rewarding patients and families that you will ever encounter. Thank you for coming on this journey with us. This concludes our 4-episode series, Treating Addiction in Primary Care. The Family Docs podcast and the Treating Addiction in Primary Care series is brought to you by the California Academy of Family Physicians, the largest chapter of the American Academy of Family Physicians, and the only organization in California solely dedicated to advancing the specialty of family medicine. To find out more about CAFP, visit familydocs.org. If you enjoyed this episode, please share with your colleagues, rate and review us on Apple Podcasts or your favorite podcast program, and be sure to come back for more. To find more resources about MOUD and substance use disorder, check out our webpage at familydocs.org/SUD. The Family Docs podcast was developed, produced, and recorded by the California Academy of Family Physicians. Support for Treating Addiction in Primary Care series is provided by the National Institute on Drug Abuse and the California Department of Healthcare Services. Thanks to Shatterproof for sharing ambassador voices. Until next time, this is your favorite family physician, Dr. Rabah Sibe with CAFP.